Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews. Today we're going to be talking about delirium and dementia. I find in my personal experience that when an Nclex test taker does not know the difference between delirium and dementia, they often have big knowledge gaps in other areas. So this is part of fundamental knowledge, and you need to know about it before you take your Nclex. So let's get started. Hello, Clinic Review family. You know that this channel is part of the greater Clinic Review organization, and we are committed to helping you pass your Nclex. You can sign up at clinicreviews.com for our online, on-demand Nclex review. It's 21 plus hours, hosted by the GOAT himself, Mark Klimek. And we also have online live tutoring. I do participate in that, so if you want to meet me over Zoom, you can do that. We also have a streaming service. So today we're going to be talking about the difference between delirium and dementia. So delirium is acute and reversible. Dementia is chronic and irreversible. You can have delirium on dementia. So if someone comes in, they have dementia. It's also, dementia is also slowly progressing. Delirium is sudden onset, right? So delirium is acute, sudden onset, and reversible. Dementia is slows progressively, comes on. It's chronic and it's irreversible. So let's say someone comes in with Alzheimer's dementia and they have a number of deficits, but they recognize their kids, they know where they are, and so forth. And then they come in and something happens and they end up developing a delirium, and now they don't recognize their kids when they come into the hospital. That's very upsetting to the kids, obviously. They think the dementia is progressing, and the dementia is not progressing. It's a delirium on top of dementia. So anytime there's an acute change, it's not dementia, y'all, it's delirium. So let's go ahead and get started with our questions, and I'll do more teaching as we progress. A nurse is caring for a 76-year-old client who became acutely confused and disoriented over the past 24 hours, which finding would support delirium rather than dementia. So we already know it's delirium because it's acute, but they want to know, do you know what other symptoms are associated with delirium? Gradual decline in memory over several years, that's dementia. Fluctuating levels of consciousness during the day, that is not dementia. Family reports of progressive forgetfulness, that's dementia. Stable attention span with word finding difficulty. Okay, so attention span doesn't change, but word finding difficulty. I know word finding difficulty is associated with dementia. So the question is, does fluctuating levels of consciousness, is that associated with delirium? And the answer is yes, it is associated with delirium. So that's just a fact you should know. And then the other things, obviously, are things you should know about dementia. The nurse is assessing an older adult with dementia. Which assessment finding is most concerning and requires immediate intervention? So we always are most concerned about unexpected findings. Unexpected findings. All right, the client has become suddenly more agitated and disoriented in the evening. That's unexpected. That's not dementia. The client is unable to remember their grandchildren's names. That's pretty consistent with dementia. The client has gradually lost the ability to manage finances. That's consistent with dementia. The client repeats the same question multiple times. Again, that's consistent with dementia. So the only one that is not consistent with dementia is that they become suddenly more agitated and disoriented. A nurse enters a room and finds a client with delirium attempting to pull out their IV line. Which action should the nurse take first? Okay, apply wrist restraints immediately, administer PRN antipsychotic medication, reassure the client in a calm manner, call the provider for sedative medication. So this is a first question. So the question is, what do we do first? Now, people with delirium are psychotic. Psychosis is hallucinations, delusions, illusions, and they do have psychosis. I mean, that's probably why they're trying to pull their IV out. They probably think someone's trying to harm them or something like that. But we have not found that antipsychotic medications are particularly, however, for this acute change, we don't usually use antipsychotic medications unless like it's our last option, right? Okay, so that's our last option. So I'm not going to do B first. Apply wrist restraints immediately. Wrist restraints, we all know wrist restraints are not your first choice. So we can choose between C and D. Reassure the client in a calm manner. So reassurance in a psych setting is a good intervention. Reassurance in a psych setting is a good intervention. I used to think the word reassurance meant they're there, everything's going to be okay, like false reassurance. But reassurance in a psych setting does not mean false reassurance. It just means you're reassuring them that they're safe, basically, and reassuring them in a calm manner, because they're probably psychotic and they think someone's trying to harm them, or they don't know what this IV is in their arm for. So reassuring them in a calm manner is an appropriate intervention, particularly as first line. Call the provider for a sedative. We don't generally give sedatives to our patients with delirium or dementia, at least not as a general rule, so I can cross off D. Certainly it's not first. So the question is, you may have, and I'm projecting my own thoughts onto you, I would say, well, I've tried that. That doesn't work. Okay. Y'all, Nclex is a perfect world, which means if the intervention is appropriate, it's going to work unless they tell you it won't. And so I need to get that thought out of my head. I need to get the thought out of my head, well, I tried that and it didn't work. What you say to yourself is this an appropriate intervention for delirium? And the answer is yes, it is an appropriate intervention for delirium. And it's certainly a first line treatment. A nurse is educating a family about risk factors for delirium. Which of the following should the nurse emphasize? So select all that apply. So remember, dementia is not the same as delirium. Delirium is an acute change in level of consciousness and thought processes and sensory inputs, and it's associated with something, okay? And usually what it's associated with is fairly predictable, okay? So what is it associated with? Recent surgery under anesthesia, dehydration, long-term hypertension, urinary tract infection, the normal aging process. So delirium is not part of the normal aging process. So you might say, well, older people tend to be forgetful. That's not delirium, y'all. Delirium is not forgetfulness. Delirium is an acute change that's associated with psychosis. And so it's not part of the normal aging process. So recent surgery under anesthesia, yes. And particularly it's the anesthesia that can cause acute chemical changes in the brain. So delirium is associated with chemical changes, and so yes, it's associated with that. Dehydration, yes, that can lead to chemical changes in the brain that is associated with that. Long-term hypertension, well, I should say vascular changes in the brain is associated with dementia, not delirium. So delirium is associated with chemical changes, whereas dementia can be more associated with vascular changes. And it's actually physical brain changes is associated with dementia, whereas delirium is a chemical change, not physical biological changes. Urinary tract infection, you probably all know that one. So these are the things that are real risk factors for delirium. I would say these are the things you have to know. A nurse is providing discharge teaching for the spouse of a client with Alzheimer's dementia. Which statement indicates a need for further teaching? So further teaching means it's a false statement. I will keep familiar objects and photos in the room. Is that appropriate for dementia? I will keep familiar objects. Yeah, that's totally fine. That helps orient them to kind of who's who and where they are. I will encourage independence with activities of daily living as long as possible. Well, yes, we always want to do that, always. Dementia, doesn't matter. We want to do B. That's a good intervention. I will keep a current calendar where my spouse can see it. That's a good intervention. It keeps them kind of up to date on what day it is. I will expect his confusion to come and go throughout the day. No. Okay, so dementia is chronic and irreversible, so it doesn't come and go. It comes slowly, but when it comes, like it doesn't get better. You don't expect a patient with dementia to have a sudden insight into the fact that they're confused. Now, early on, they may realize they're getting confused, but later on, they may know they're confused. They may know they're confused about certain things because they can't remember things. But it's not like all of a sudden they're going to have insight one day and then remember everything that they forgot. That just doesn't happen. So there's no changing of mentation throughout the day. Which client is at highest risk for developing delirium? A 67-year-old with Alzheimer's disease living at home. Okay, so risk factors, I count the number of risk factors. That's how I choose an answer. So I don't always count. Like when it says, which patient will you see first? I make that decision based on who's unstable. I don't count number of unstable things. I just say who's unstable. But for specific to risk factors, I count the number of risk factors. So delirium is not a normal part of aging. So the age doesn't matter. Alzheimer's disease, living at home, so having dementia could possibly put them at risk, but they're living at home, which means they have a stable environment. So I don't see them as they have one risk factor. 72-year-old postoperative client, post-op, so that's one, receiving opioids. There's another one that can cause chemical changes with the UTI. That's three. They have three risk factors. See, a 67-year-old with longstanding hypertension and diabetes, those are not risk factors. Those change physiology, not chemistry. A 78-year-old with a 10-year history of progressive memory decline, that's one risk factor, because remember, age it's not a part of normal aging. So the person with three risk factors is going to be who I'm going to pick, and that's B. A nurse conducted an assessment of a new patient who's 82 years old and has had osteoarthritis for 10 years and diabetes for 20 years. Okay, fine. So those aren't significant risk factors for really anything, maybe some dementia, but dementia is more physiologic changes. There's a lot of genetics associated with that and other vascular changes. Okay, he's alert but becomes easily distracted during the assessment. All right, easy distraction, easily distracted. That's not a real significant finding related to dementia or delirium. He recently moved to a new apartment, so he's in a new space, and his pet beagle died just 2 months ago. Oh, that's very sad. What's he most likely experience? Dementia, depression, delirium, or anxiety. So I can cross off anxiety and I can cross off delirium, because there's no acute onset here. Okay, so I can definitely cross off delirium. So is there progressive memory loss? I don't see it. He becomes easily distracted during the assessment. There's no progressive memory loss. It doesn't tell me he's losing words, that he doesn't know where he is. So really, there's no evidence for dementia. Now, this is not a strong case for depression, but it's the only one that it could be. There's no evidence of any of the other things. So, being distracted is not necessarily evidence of depression, but he has had changes. He's had a loss of a pet. So that's the only one it could be. So remember, when you're picking an answer, when it says he's most likely experiencing which one, it's saying out of these four. So don't say, well, it could be something else. I don't think that's depression. Okay, but it can't be anything else. So out of these, you only have these four options. So out of these four options, which one is most likely? Okay, so that's really what it's asking you. So make sure it's not saying which is most likely out of the unlimited number of possibilities. That's not the question. It's saying out of these four, which is most likely. 4 older adult clients are assigned to you. Who should you assess first? So we're looking for the patient who's unstable. Alzheimer's disease, who's repetitively asked the date. Well, that's an expected finding, so that's not unstable. Vascular dementia with stable gait disturbance. It uses the word stable, so I'm not going to pick them. New acute confusion after starting oxycodone post-op. That's a new change. That's a change. So a changing assessment does make someone unstable. Mild cognitive impairment awaiting discharge education. There's nothing there that makes them unstable. So it's the changing assessment that makes them unstable. Which medication is most likely to worsen delirium in an older adult? Okay, delirium. Diphenhydramine at bedtime, rivastigmine patch, acetaminophen, a melatonin at bedtime. So rivastigmine is actually medication used for dementia. It's used to treat dementia, and it doesn't have a risk factor of causing delirium. Acetaminophen does not have a risk factor of causing delirium. So I'm looking at 2 meds that are given at bedtime. Both of them are used to help people fall asleep. So out of these 2, you would just have to memorize it. And diphenhydramine is the one that has been found to worsen delirium. So I don't know what it's like at the hospital where you work, but I have found at the hospitals in my area, because when I was a new grad, we used to have a standing order for Benadryl at bedtime for people who needed something to help them sleep. It was like a standing order. And that's not they got rid of that a long time ago. But recently I've been seeing melatonin as a standing order in some hospitals, depending on the physician. So diphenhydramine, can cause confusion, particularly those who are at risk for confusion to begin with. Which bedside assessment best supports the diagnosis of delirium? Which bedside assessment best supports the diagnosis of delirium? Mini cog score 2 out of 5. Okay, I don't know what that is. I mean, I can figure out what it is. Like, it's a cognition score, so maybe. Inability to recall 3 words at 5 minutes. That seems more associated with dementia. Clock drawing showing planning deficits. That seems more associated with dementia. Acute onset inattention and disorganized thinking. So obviously that's it. So A, B, and C are all dementia. You don't do a mini cognition, like whatever mini cognition test you do. I mean, it could be the mini, there's no different ones. Mini mental exam might be one. You don't use those for delirium because delirium is an acute onset and it's usually pretty big change, whereas dementia is progressive. So someone maybe initially start forgetting words and you think, oh, I'm getting older. But then they start to forget how to get places, right? They forget how to get to church when they've been going to church every week for 50 years. And so they may forget how to get places. And then the family starts to suspect maybe this is more than just aging. And so they bring them in and they do like a mental. They ask them for word recalls because it's subtle still. It's still fairly subtle. So you do these A, B, and C tests when it's subtle. But delirium is acute and it's very obvious to everybody that there's been a big change, like suddenly. A client with severe Alzheimer's becomes physically aggressive during bathing. Which nursing actions are appropriate? Okay, so it would be appropriate when an dementia patient becomes physically aggressive to stop and attempt later with a different caregiver in simpler steps. Yes, that would be appropriate. For a patient with dementia who becomes physically aggressive, it would be appropriate to use calm tone, offer choices, and validate emotions. Yeah, I think that would be appropriate. You don't want to offer too many choices, but you can say, do you want this shirt or this shirt? Or do you want to sit or to stand? Like that's true. And what you don't say is, well, if I do A, I can't do B. No, it's a SATA question. So how the answers relate to each other doesn't really matter. It's how the answer relates to the question that matters. So it would be appropriate for a patient who becomes physically aggressive during bathing to apply 4-point restraints immediately? Absolutely not. For a patient with dementia who becomes physically aggressive during bathing, it would be appropriate to assess for pain, constipation, or fear contributing to behavior. Yeah, that would definitely be appropriate. For a patient with dementia who becomes physically aggressive during bathing, it would be appropriate to increase water temperature to finish quickly. No. No. All right, let's just burn them. No. Let's sterilize them with hot water. Oh, goodness, that is not the right answer. Okay. Well, I hope this was helpful to you. It wasn't particularly complicated, but the difference between dementia and delirium is super important for you to know during the Nclex. So hopefully it was helpful to you. And thank you for being a part of the Clinic Review family. We love you. We love hearing from you, whether you passed or didn't pass, or how we might have been helpful to you. It's great. We love to see that in the comments. So love you guys. See you later.